And what I'd like to focus on next is really, is there a correlation between the insertion torque and ISQ? So what is important for us? What do we really need to know? And so I perform a tremendous amount of immediate tooth replacement therapy in my practice, mainly extracting anterior teeth, placing an implant at that same time, grafting it, as you'll see, and placing a temporary crown. And so there was a lot of controversy going back several years in terms of how much stability or insertion torque is necessary to perform this type of treatment. And is there a correlation between the insertion torque and the ISQ in immediate placement? And so, like any periodontist, we're born on the literature, and I went and searched, and I saw a very good study from Philippe Cayet, who talked about very high insertion torques, much higher than something that I would ever be comfortable with in a healed site, and finding that there was really very little difference in terms of marginal bone loss 1 year after placement, which is important. But I also think it's important to look at the type of implant that was placed here, where we would anticipate about 1 millimeter of crestal bone remodeling, not necessarily loss, but remodeling physiologically around that polished collar. And how does this differ from the kind of implants that we're placing today? And are there ramifications in terms of what type of implant is actually being placed? The other side of the coin is that low insertion torque camp, where Reva Bearwell's group with Clark Stanford showed that really 20 Newton centimeters is sufficient insertion torque to immediately temporize an implant in a healed site. So I set out to try to figure out, is there a correlation between these two parameters? Does insertion torque and ISQ correlate with immediate placement in a non-molar site? And so this is an example of one of the patients in the study where insertion torque was only 20 Newton centimeters, but the ISQ values were very high. On any chart that you will find, ISQ values of 74 and 71 would be considered favorable in terms of anticipating, one, integration, and two, if we were going to temporize the implant. Now, this patient opted not to have a temporary and wore a removable appliance, but this was interesting to show that what would be considered possibly a low insertion torque did not correlate with a very favorable ISQ value. And so we perform our dual zone grafting here with a composite of allograft and xenograft. A dermal allograft was used as opposed to a connective tissue graft just around a stock healing abutment. And at 8 weeks, we take another ISQ value, and we see basically just stability. We don't see a dip, and we don't really see much of an increase, but we had a very high value. So we're feeling confident that after a few more weeks of soft tissue maturation, the patient can proceed to final restoration. And so when we look at these two variables, insertion torque and ISQ values, both at placement and at follow-up, the goal was to figure out if we have a correlation here. Is there one? And if so, what is that correlation?